My name is Amanda Mathieu. I'm a registered nurse and certified diabetes educator.
And I'm Heather Fisher, registered dietitian and certified diabetes educator.
And we're today excited to talk to you about what's happened since the discovery of insulin.
So we do not have any relationships with for-profit or not-for-profit organizations, and this program has not received any financial or in-kind support.
We've developed 3 learning objectives for today, and they're all very different. The first learning objective is to describe the history of insulin and how it has transformed the course of a life-threatening illness. The second learning objective is to describe what is new in the pharmacological glycemic management in type 2 diabetes. And the third learning objective is to identify and utilize technology that can be used by people living with diabetes and their circle of care to support their self-management.
So we'll go over the history of the discovery of insulin and what came next. We'll provide an update on what is new in the pharmacologic management of type 2 diabetes, and we'll review technology that's now available to support self-management.
So objective number 1 is describe the history of insulin and how it transformed the course of a life-threatening illness. We're going to share some highlights on a timeline format from the discovery of insulin and up to today. This is a video that is going to just give a little summary, so we'll just listen in.
Hi guys, I don't know if anybody else can hear the video, but we can't hear the audio.
Oh. Do we go
Thank
back?
you. Okay. Kathy, do you know?
Should we go back?
Kathy, I can't hear you.
Try going back and then increase the volume for the actual video right in the bottom left-hand corner of your screen.
Okay.
Hit play and then
I have to make it smaller. It's already at 98.
Okay. So we'll see if we can try it again.
Slideshow. Current slide.
Hear that? Can you hear it?
no, but at the bottom, if
No
you go to
sound.
the bottom of your screen, there's a little, yeah, right there. Oh, it's already.
I think if you guys maybe hit the mute and unmute button and then go to same as system instead of built-in microphone, maybe that would help. Bottom left of your screen. That's how it shows on mine.
I don't see it.
Under see the mute button, and then there's a little arrow up, gives you a menu.
Is that it? No. What's that?
Oh, I don't know what you got into now.
Okay, close that.
Sorry.
Yeah, okay.
Can we maybe just send it to everybody afterwards?
Absolutely, yeah.
We'll just move on.
Okay, I need to get out of this. Slideshow.
Go to the next slide.
Here. Okay, sorry about that.
Oh, can we make it big?
I am gonna make it big.
Okay, sorry about that. That's unfortunate. I hope we can hear the other videos that we have embedded in this presentation. So I'm just going to read to you a little history about Frederick Banting. Frederick Banting was trained as a surgeon rather than a research scientist, so his exposure to the emerging discipline of endocrinology was minimal. He was born on a farm in Alliston, Ontario, and graduated from medical school at the University of Toronto in 1916. He served as a frontline battalion medical officer during the war, and when he returned to Toronto, he began a residency in general surgery at the Hospital for Sick Children, but was unable to secure a permanent surgical position. He then tried to set up a private practice in London, Ontario, which was largely unsuccessful. And to supplement his income, he worked part-time as a demonstrator in surgery and anatomy at the University of Western Ontario, assisting Dr. F.G. Miller, a professor of physiology. In 1920, Banting was introduced to the idea of a therapy for diabetes while preparing a lecture on carbohydrate metabolism for his physiology students. The night before his talk, he had read the article titled "The Relation of the Islets of Langerhans to the Diabetes, with special references to the cases of pancreatic lithiasis," written by Moses Brown in the November issue of the Journal of Surgery, Gynecology, and Obstetrics, which had just arrived in the mail. During a fitful night's sleep, Banting began piecing together a synthesis of carbohydrate metabolism and pancreatic ligation, writing the idea in his journal, which is the image that you see on the screen. It's hard to read, so I'll tell you what it says. Diabetes. Ligate pancreatic ducts of dog. Keep dogs alive till acini degenerate, leaving islets. Try to isolate the internal secretion of these to relieve glycosuria. Banting presented his idea to Dr. Miller the next morning, but Miller did not support the idea of embarking on this project. He suggested that Banting speak to J.J.R. McLeod at the University of Toronto, who was an expert in carbohydrate metabolism. Banting met with Professor McLeod on November 8, 1920. McLeod was skeptical and found Banting to be neither well-versed in the subject nor sufficiently skilled in physiological research. But in the end, McLeod agreed to accommodate Banting in his research at the University of Toronto. He introduced Banting to two students that would serve as his assistant. The two students flipped a coin to see who would begin the research with Banting over the summer. Charles H. Best won, and I put it in quotation marks.
Okay, so what happened in Toronto? This is a direct quote from a book written by Michael Bliss, a historian. The discovery of insulin at the University of Toronto in 1921 through 22 was one of the most dramatic events in the history of the treatment of disease. Insulin's impact was so sensational because of the incredible effect it had on diabetic patients. Those who watched the first starved, sometimes comatose diabetics receive insulin and return to life saw one of the genuine miracles of modern medicine. They were present at the closest approach to the resurrection of the body that our secular society can achieve, and at the discovery of what has become the elixir of life for millions of human beings around the world.
Heather, do you remember about 10 years ago, we went to the Canadian Diabetes Association conference in Toronto?
I do, yeah.
And we were able to listen to Michael Bliss speak what was then the 90th anniversary of the invention of insulin. Do you remember how that room felt?
Yes, it was full of people who live with type 1 diabetes. It was full of diabetes educators, and there were tears, there was emotion. It was very powerful talk.
It did. It made the hair on my arm stand up. I felt very emotional, and it really changed my perspective on insulin. And I always just took it for granted. It was another tool in the toolbox, but really, I really feel pride that it's Canada's gift to the world.
Okay, so here we have, this is a photo from 1921. This is Banting and Best with test dog number 408. So during this time, they created a diabetic dog by removing the pancreas. Secretions were extracted from the dog's pancreas and then injected into a diabetic dog, and they would test the effect. A reduction in glucose was often seen, but the dogs often died. And this was related to the poor surgical conditions. The operating tables were wooden and could not be sterilized, and they lost many dogs in the process. Finally, in the end of 21, early 22, Collip, a biochemist, was brought on board, and he was able to purify the extract to make it safer for human use. So here we have Leonard Thompson. This was the first patient to receive insulin in 1921. He weighed just over 29 kilograms and was 14 years old. This is an after photo. There are no photos from prior to his being given insulin. Leonard was given what was described as a brown muck, and it was deemed a failure. But 12 days later, a more purified version of insulin was given to Leonard, and it did have the desired effect. He was able to live for 13 years, and his death was a result of bronchopneumonia and complications from diabetes. But certainly the extra years he got were as a result of receiving insulin. This insulin that he was given was from the pancreas of cattle from the slaughterhouses.
So he didn't get dog insulin. So we're just going to share again here some more before and after, some early recipients of insulin. So you can see the picture on the left, child JL, age 3, 15 pounds. And just a couple of months later, JL on the right after receiving insulin and almost doubled in weight. It's dramatic difference.
Here we have Teddy Ryder. He's very, very famous early recipient of insulin. This is pre-receiving insulin. This was an article that was written about Banting's discovery and where he was at with his research. And here we have Teddy Ryder after receiving insulin. And this is a letter that he wrote to Dr. Banting. It says, "Dear Dr. Banting, I wish you could come to see me. I am a fat boy now and I feel fine. I can climb a tree and Margaret would like to see you. Lots of love from Teddy Ryder." So these examples are just to highlight the remarkable result of the insulin on these children. Teddy Ryder lived to be 76. He passed away due to heart failure in 1993. And at that time, he was the person to have been treated by insulin the longest in the world.
So along the timeline, a Nobel Prize was awarded in 1923 in physiology or medicine. And the prize was split between Frederick Banting and John James R. McLeod. This was a very controversial Nobel Prize. Banting shared his money with Best, and McLeod shared his prize money with Collip. Each member of the team brought his unique talents to the table. Banting provided the passion behind the project, and without him, there would not have been the impetus to search for insulin in Toronto. Best was a stabilizing force in Banting's scientific life, keeping him focused. Collip's expertise in biochemical technology was the key to formulating a clinically useful drug, and McLeod had the sophistication to guide the research from spark to clinical trial. It is impossible to isolate the most important of these contributions. Each of the four scientists had a specific role in the discovery of insulin.
Okay, so in 1946, NPH was first discovered. This was discovered by Hans Christian Hagedorn, and it is called neutral protamine Hagedorn insulin. This prolongs the effect of the insulin and meant that people with diabetes could receive fewer injections, which meant fewer complications from the injections. Early insulin use often had the result of abscesses from the injection site. And this was due to technique and also the sterility of the needles or syringes. Here we have the first insulin pump. So this is an interesting photo. The first insulin pump was created by Dr. Arnold Kadish from Los Angeles. The size of this pump was approximately the size of a microwave. This pump delivered both glucagon and insulin. And within the next 10 years after it was invented, research was conducted to find an alternate device that could deliver insulin more effectively. This was 1963.
It wasn't terribly convenient.
Here we have an example of one of the first blood glucose meters. So in the 1970s, blood glucose monitoring for personal use was begun. This helped people to be able to monitor their glucose at home. So this is the Ames reflectance meter. This was also around the same time that the hemoglobin A1C first became available for clinical practice, and it became the accepted marker of glycemic control.
So again, moving along our timeline, it took nearly 30 years to standardize the strength of insulin. So in 1973, they decided that it should be 100 units per mil as the standard dose or strength, of insulin. You can see some images here, U40, U80, and then U100. So there are a lot of errors, obviously, in dosing and calculations. So this was a good thing, but it took a long time to come. Moving along the timeline, in 1982, cumulin insulin became available as the first therapeutic protein to be created using recombinant DNA technology. This is a human insulin, obviously not from another human being, but it's identical to the insulin produced in our bodies. It's highly purified and was produced in unlimited quantities, so it greatly expanded access for people living with diabetes. Cumulin R is still available today, unfortunately. It does have, I guess, specific uses. It's useful in people living with gastroparesis. Cumulin N is also still used today, but it's more geared to a steroid-induced hyperglycemia. It has a good matchup for that. And then 3070 came along as well and was very popular in its day, which was a combination of the two. It was 30% R and 70% N.
Okay, so here we have progressed to a smaller insulin pump. This is about the size of a calculator. So pumps became widely available in the 80s, and this was a bit more convenient than the first pump that we showed you.
And then now we've come a long way. This is one of the first syringes. The top one is from 1925. And then the bottom one is one of the first insulin pens that came out in 1985. Luckily, we've come a long way to the pens that we use today. So here are some images of the pens that we use today. They are pre-filled and convenient and safe. There's less handling for the patient in terms of not having to handle a cartridge or anything like that. The Novo Nordisk Flex Touch pens, which would be where the Tresiba pens are here, they actually deliver the insulin for the patient. You can see with the Lantus pen here, the patient actually uses their thumb to push the insulin in, whereas with the Novo Nordisk pen, there's a mechanism within the pen that delivers it at a nice even pace. Insulin glargine, also known as Lantus, has been around since the year 2000, which I find that incredible. It's been that long already. Toujeo, known as insulin glargine 300 units per mil, came out in 2018, as well as the Tresiba, which is known as Degludec. They came out in 2018, so they're kind of the newest kids on the block.
All right, here we have examples of some insulin pumps that are currently used. This is the Omnipod. This is tubeless, and it connects to a client or a patient's phone. This here we have is a Medtronic pump, and we have here the continuous glucose monitoring system being used as well. So pumps are fantastic tools, but they are not for everyone. One risk that people face on a pump if they're not skilled at managing is that they could run into a risk of DKA or hyperglycemia much faster than they would if they were taking a basal insulin, because if the pump malfunctions or stops delivering insulin, they get into trouble quite a bit quicker. It also requires some very detailed carb counting and knowledge. People need specific training for pumps, and they attend education or pump school with certified pump trainers. So they don't think for a patient, and so they're a very good tool, but they are not for everyone that lives with type 1 diabetes.
And then coming to the end of our timeline, I've titled this Canada Celebrates. So if you look on the back of a $100 bill, there is an image of insulin there. So that's a commemorative nod to the invention of insulin. In 2021, Canada Post came out with some commemorative stamps marking the 100th anniversary of the discovery of insulin. And in 2021, science, technology, and innovation inductees were the 4 gentlemen who were responsible for the discovery of insulin. They were inducted into Canada's Walk of Fame.
Okay, objective 2. We'll move on to our next objective. Describe what is new in the pharmacological glycemic management in type 2 diabetes. Okay, so this is a slide that you may recognize. It's from the clinical practice guidelines. And what we'd like to note in this area of the presentation is that the clinical practice guidelines are typically updated every 5 years. However, this update was released in 2020 due to the compelling evidence to change the guidelines. There's 4 reasons why they did this. The first being additional agents approved for use in Canada have been shown to have cardiovascular benefits in patients with type 2 diabetes. The second, some of these cardiovascular benefits have now been demonstrated in people with cardiovascular risk factors, but without established atherosclerotic cardiovascular disease. Third, there is more evidence showing that SGLT2 inhibitors reduce the risk of hospitalization for heart failure and the progression of chronic kidney disease. And fourth, additional studies of comparative effectiveness of anti-hyperglycemic agents provide stronger evidence that GLP-1 receptor agonists and SGLT2 inhibitors are associated with greater weight loss compared to other agents. So this slide would walk you through how to get started to achieve a patient's goal of an A1C within 3 months. So you could begin with lifestyle, or you could begin with metformin if the A1C is above 1.5, more than 1.5% above target. And then at 3 months, if the A1C is not at target, this is how we would progress. So the difference is after 3 to 6 months. So we'll go on to figure 2. So this is a change. So if your A1C of your patient is not at target at 3 to 6 months, and you're going to adjust or advance the therapy, we would look to see, does your patient have atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure? Or are they over age 60 with 2 cardiovascular risk factors? If so, there's different agents that you would go to than in the previous guidelines. So you would go to a GLP-1 receptor agonist or an SGLT2 inhibitor. With chronic kidney disease, you would go to an SGLT2 inhibitor, or you could, and then a heart failure, SGLT2 inhibitor, and the GLP-1 receptor agonist if they're over age 60 with the risk factors. If the A1C is above target and they need to reduce the sugar, the glucose, but they don't have the risk factors, again, you can go to those same newer agents because of the weight loss factor. So we would no longer be going directly to the sulfonylureas or the insulin or the TZDs due to the weight gain piece. So I'll go back to, on the first slide that we did, there was a third window, and it said that you may have to start insulin as well as metformin. So we've started basal insulin now.
That's your first, you want to go back to your
So
first
here, so if we had to start our client on insulin and metformin because their A1C was so elevated, we would move on as a next agent after 3 to 6 months. If they were not at target, we could go, instead of going straight to rapid insulin or bolus insulin, we could add a GLP-1 receptor agonist or an SGLT2 inhibitor. And then if we're still not at target, we could add bolus insulin at 1 meal a day. So we call that bolus plus, generally the largest meal. And then we would go to MDI. So it's just a little bit of a different order based on the evidence that they've found over the past little while. They didn't want to wait to change these guidelines till the next update. Now, if you haven't already seen it, the Diabetes Canada does have a clinical practice guidelines app that's free. It's quite a nice tool. You can go into the app and plug in the details of your patient, and it will walk you through the steps. You put in the risk factors, and it will recommend what agent would be appropriate for use for that patient. So it's pretty handy if you haven't used that.
So thanks, Heather, that was great. Some of the newer oral agents on the market, one of them is called Ribalysis. It's semaglutide in a tablet form, which is a GLP-1 receptor agonist. It has a similar titration schedule. The starting dose is 3 milligrams daily. And after 30 days, you would increase to 7 milligrams daily, and that would be your typical maintenance dose. There is a maximum dose of Ribalysis at 14 milligrams per day. It has some parameters around it in terms of how it has to be taken, and these have to be followed very carefully. Ribalysis has to be given on an empty stomach, 30 minutes before food or any beverage. It must be taken with no more than 120 mils of water. The side effects are very similar to semaglutide by injection, which are nausea and vomiting, diarrhea, constipation, decreased appetite, and weight loss. So the decreased appetite and weight loss are desired side effects, actually, and that's how this agent is, this group of drug is very popular. Ribalysis currently is only covered by private insurance.
Yeah, we don't see it too often.
I don't think we have anybody on it actually at this time.
Okay, so injectables. Now, while these are not brand new, they are the newest available, so we wanted to go over them. We have the class, the GLP-1 receptor agonists, which includes semaglutide or Ozempic and dulaglutide or Trulicity. These are once weekly injections, and they are, very popular now. Specifically, semaglutide we see a lot. It's covered on ODB, so it's really exploded the use, and it's really quite good. The longer acting insulin, so we have the insulin degludec or Tresiba, and the glargine 300, which is the Toujeo. So Toujeo is a concentrated insulin, if you will. So the volume of the insulin injected is smaller. There's also less risk of hypoglycemia. Tresiba is ultra long acting. It has a very smooth profile. And in some of the studies done, it's a 30% less risk of hypoglycemia in people living with type 1 diabetes overnight. And to give you an idea of the volume, if you were to inject the glargine, if the volume of Lantus or regular glargine was the size of a loonie, the glargine 300 or Toujeo might be the size of a dime for the same amount of insulin given, because it's so much smaller
So
volume.
if you have people on a large dose of insulin, Toujeo might be a better option in terms of giving them less volume into that injection site. Another new treatment that has been released is called Baxemi. This is a glucagon nasal powder. It was invented in Canada. It is, again, only covered by private insurance. This is a ready-to-use treatment for low blood sugar, and it doesn't require any need to be inhaled. So it's great. It just can be opened and used. So it's a little bit easier than glucagon, which is an injection that has to be, there's a little bit of education associated with glucagon. So this is quite a bit easier.
Objective 3, we'll move on to technology. Identify and utilize technology that can be used by people living with diabetes and their circle of care to support their self-management.
Well, I'm sure everybody's aware of the new, the freestyle flash glucose monitoring system known as the Libre. The flash glucose monitoring is now also being referred to as intermittently scanned. So it's just a new term that we're seeing used for the Libre. Here we have an image of the Libre on the arm and the client using a phone as the scanner instead of the reader. The sensor is actually not placed correctly in this image. I just wanted to point that out. It's typically more to the back of the arm where it's a bit more protected. Now we have a video. We don't know if you're going to be able to hear it or not, but you can watch some of the images. Maybe it might be helpful. I don't know. Well,
Kathy, are you there, Kathy?
Yes. Yep.
Yeah. So can you just let us, I mean, should we go ahead and just play? I'm not sure.
Well, you can try, and if it's not going to play, like with sound, then we'll just send the link.
okay.
Okay. Let us know, okay?
Yep. I'm not hearing anything. No, I'm still not hearing anything.
Okay.
Sorry. Best laid plans. It was a great video.
Yeah, we'll send a link. We are going to go over the technology. We have some images that we're going to share.
Okay, so we have a second video. Again, you're not going to be able to hear it. This video is really cool. I hope you'll be able to watch it separately. It explains the difference in the numbers. So often clients will say, you know, when I do a blood test and then I do a scan, the numbers are not the same, and they're not going to be the same. There is a expected difference in the numbers, and the scan glucose is actually measuring interstitial fluid glucose, and obviously the finger prick is measuring a blood glucose. The difference between the two is called the lag. And so as the blood glucose rises, the scanned glucose will be lagging behind. Things may level out and they might be a little closer together. And if the blood glucose starts to drop, the scanned glucose will lag behind. So there's always going to be a difference in most circumstances between if someone did a capillary blood glucose finger prick versus doing a scan. And just wanted to add that while Libre has the market, I'm sure we can expect to see that other companies will be coming out with this type of technology in the near future.
Okay, so this we wanted to go over. This is an image of what we can see through the Libre View app. So if our patients consent, we send them an email invitation or we connect them with our clinic code. And then we can see their scanning and we can do virtual visits, or we can print this out, we can share it. And it gives us a lot more information than the blood glucose report would have given, or a logbook. So I'll just go through it briefly. So up at the top, this is something we would look for, the time, the % time sensor is active. This is important because if the client or patient is not scanning very often, we won't be gathering as much data. So we would like to see this number up over 80% in order for us to make, for this data to be valuable for us. Okay, so next we've got the glucose management indicator. So this is not.
I'm sorry, ladies. I don't see the slide that you're on.
You don't. What? Kathy, can you see it?
No.
What? Oh, resume share.
Resume share. I'm sorry.
That was our fault. Can you see it now?
Yeah, the Libre View app. Yeah.
Okay, sorry.
My
So
bad, sorry.
it's okay. At the top, we've got the % time sensor is active. So I was saying 80% of the time is what we would like the sensor to be active. So 3 to 4 scans per day, separated by no longer than 8 hours, will gather more data. That makes it valuable for us. Here we've got the glucose management indicator, which is not unlike an A1C result. So it only is good for the time of the report, but it does give us an idea of how they're doing if we don't have blood work available to us. The ambulatory glucose profile, this is how we can look to see how a client is doing, because sometimes the glucose management indicator might be quite good, but it might be related to variability. So we look to see, is there any hypoglycemia? So this lower green line is 3.9. And if the graph dips below there, we can see if there's hypoglycemia. We look to see if the dark blue line, the median line, is within the target range. So we tend to set the target range at 3.9 to 10. And here you can see the median line is definitely going above that. So that's something we would peek at. Are there steep rises and falls in the median line? That gives us information, because you could have a good A1C with lows and highs. Is the shaded curve wide or narrow? So we'd like the curve to be nice and narrow for tight control. The last thing that we look at on this slide is the time in range. So we would like our clients to be at 70% of time in range. That would be a goal. We would like them to be low, less than 4% of the time, low or very low, and we'd like them to be high, less than 25% of the time, because that starts about 10. This is an example of a daily log that we would see, and so this can help us to identify what time of day they may be having trouble. We can look to see where lows occur, if there needs to be changes, if we need to make recommendations. So this is quite helpful for us.
And any gaps you see in the line just means that they haven't scanned, or there may have been some kind of problem with the sensor. So the dots represent when the person scanned.
Okay, and then this is a closer screen view of the glucose management indicator. So again, similar to the A1C, but they're not allowed to call it that. It isn't an A1C. The A1C, while we know is the gold standard, does have its limitations. It's a poor indicator of variability of glucose, and it can be confounded by certain conditions such as renal failure. And it provides an average measure of glycemia. It doesn't tell us the whole story. So metrics in the Libre do help us understand a little bit better. We know that less glucose variability means better control. So glucose variability is correlated with more frequent hypoglycemia. So the bigger the glucose variability, the more likely there's lows. It's also increases the risk of retinopathy and nephropathy, the more variability that we have. Okay.
So this is another app that we have available. So the OneTouch Reflect meter has a OneTouch Reveal app associated with it. the client would put the app on their smartphone, and the meter and the smartphone talk through Bluetooth technology. They can then share their data with a clinic. We give them a clinic code, and then we can look at their things together. This really has improved our virtual visits with people, because it gives us a lot more information to see where there are problem areas. So we get some visual cues, green obviously being good, red being out of range. This particular meter is really good for actually people having gestational diabetes. So we can really set the targets, and for gestational diabetes, as this little logbook here shows, these targets have been set for gestational, which are actually a lot tighter than the people living with diabetes. So we can set the tight targets for gestational and then quickly see where they're out of range. So you can see the red numbers are out of range for this particular mom. So it's very helpful information doing a phone visit and looking at this data on the computer.
All right.
So we use these two books here to do a lot of the work, that the history of insulin, the reading. So we recommend these two books as recommended reading if you're interested in the history of insulin. Michael Bliss has released a 100th anniversary discovery of insulin. It has sold out. I was unable to get a copy, but the information in it is much the same. I think it's just the preface that has changed. And the book on the right is called Breakthrough. It's more of a story about Elizabeth Hughes, who was, again, another early recipient of insulin. She was American. She came from a wealthy family. Her father was a politician. And it goes back and forth about how Elizabeth's life went, and then back and forth to what was going on with Banting and Best in their discovery of insulin. So it's an interesting read, more of a story rather than, scientific.
Yeah.
Thank you, Heather.
Yeah. All right.
So that brings us to the end of our talk. We're hoping that, like, for us, learning about the history of insulin has really changed the way we talk about it with our patients, especially even that talk that we went to 10 years ago. It's not a threat, it's a gift. And we hope that you feel the same way about that. Just for your information, on November 14th is World Diabetes Day, which also happens to be Dr. Banting's birthday. So if anyone has any questions, we'd be happy to answer them now. Do we have to look at the chat thing, Kathy?
I've got it pulled up. There's no questions in it.
Okay.
All right, perfect.
Sorry about the videos, Kathy. You can share those for us. They're really quite good. And
Yeah, I've shared them already.
Oh,
Okay.
thank you so much. Sorry about the video part. They were probably one of the best parts of the talk.
yeah, they're only a few minutes if you have time to watch them.
All right, does anyone have any questions?
You
About
can go ahead and unmute anyone if you have a question.
We don't have to unmute, they'd have to unmute. Maybe.
Yeah.
Yeah, okay.
I don't know how to get
We
rid
don't
of it.
even see ourselves anymore.
I got rid of it because it was in my way.
Oh, stop sharing, and then you should,
Stop sharing. Okay.
yeah, at the top.
The
So,
red?
Thank you.
Oh, there we are.
Okay.
All right, no questions? Any comments, any feedback? I'd love to hear from you guys, what your thoughts are.
Very well done, ladies. Thank you very much. I really appreciate that. It was nicely organized and very easy to follow. So great information. Thank you.
Thanks, Millie.
Thanks, Millie.
Yeah, thank you very much. And thanks for all the help with our diabetic patients all the time.
You're welcome.
It's our pleasure. It's funny, I think Heather and I are very passionate about, the history of insulin and everything. And so we really want to share that excitement and passion with you guys. So we want to maybe you guys think we're silly that we get so excited about something, but that's just our feelings and thoughts about it.
If you have questions, we're always available. If people have questions along the way, don't have to have them today as well.
Okay. I'm
Sure.
not here.
Just
Oh.
try talking now.
Here? Did I
No,
miss you?
just in general. It's this system right here.
Okay.
Yeah.
Hi.
I can hear you.
Hi.
Hi.
Hi, can you hear me?
Yes.
I just want to know, have you come across anybody who is allergic to insulin?
We've had people that are intolerant to different types of insulin. So for example, if they don't tolerate one basal, they may try a different basal and see how that goes. It's not common, but it is possible.
Yeah.
We've had the odd person.
We have had the odd person.
Yeah.
And, but I have a patient who is allergic to everything, almost every insulin.
Yeah.
He developed severe headaches.
Oh,
And I try to use Victoza, the same thing. Now I have just started him on Ozempic,
yes.
and he's still complaining about headaches.
Headaches.
And his blood sugar is way out of control.
Yeah.
Mm.
And does he not have headaches when he's off the medication? Maybe it's not related to the diabetes medications.
It seems like when I started him on Ozempic, that's when he got headaches.
Okay.
And as I increased the dose, of course, the headaches got worse.
Okay.
But since we are running out of anything to work on his high sugars,
Yeah.
even Metformin, if I give him 1,000 milligrams, he said he had diarrhea 5-6 times
Yeah, that's
a day.
uncommon.
That's
So
possible. Yeah.
that's why we start on a low dose of metformin and gradually increase the dose for tolerance. I don't know if a referral to a endocrinologist or a diabetes specialist might be helpful.
I'm thinking of doing it, but actually I sent him for an allergist to find out if it's really true that he's
Yeah.
allergic to insulin.
Yeah.
The allergist said that he is not really allergic to insulin.
Right.
So we started him back on insulin. We tried different kinds.
Mm-hmm.
Like I thought maybe, certain kinds will cause problem. But anyway, it's like a standard thing. Headaches, severe headaches. That's what he complained.
And that would.
And I'm running out of anything.
But
Yeah.
would he have
Related
would he have headaches because of hyperglycemia
No, it's just that when you take his
related to the medication?
Yeah.
Mm.
So anyway, I don't know that he was sent to Dr. McFadden in the past, but I think he wasn't followed, I think.
Oh,
Actually.
it sounds like a
I'm gonna send him
challenge.
back there, but I don't know what to do with him.
Yeah, it sounds like
Yeah.
a challenge for sure. There are endocrinologists in Huntsville and Sudbury.
And
I
Very
did
well.
send him, actually, he was sent him even to St. Michael's diabetic clinic there.
Okay.
And here again, they try to do some allergy tests and all of that and send him back saying that he's not allergic to insulin. But he is having a severe headache, so
Mm.
that's a thing. Anyway, I think I might send to someone else. I
Yeah,
don't know
it
what
sounds
to
like
do
a
with
real
it.
Another
challenge.
opinion.
Yeah, it sounds like a challenge for sure. We get them.
Okay, that's all. Thank you.
Perfect. Thank you. Have a good day.
Thank you. You too.
Bye-bye.
Bye.
Oh, hi, Millie.
Thanks, ladies.
Thanks.
Thanks, Millie. Okay, I guess that's
That good?
I think so. Thank
Okay.
you very much.
I'm really sad the
Thanks.
videos didn't work.
Yeah.
Yeah, it was funny because they worked yesterday.
I wonder